as you just mentioned, impact of AV access on cardiac function in hemodialysis. This is something that is often under-recognized, and very often this clinical scenario is missed, or it's overlooked, and the symptoms are attributed to everything else but the AV access that probably would be the main reason why some of these patients have symptoms of shortness of breath despite being very compliant with hemodialysis. So today what I'm going to try to do is start off with this case presentation that kind of gives you an idea as to what my subsequent talk is going to cover. So here's a 64-year-old patient, and this is a true real-life patient who was admitted to the hospital with worsening shortness of breath and florid signs of pulmonary edema. He's been dialyzing with a right upper arm brachiocephalic arteriovenous fistula, and generally gains about 0.5 to 1 kilogram of fluid weight in the interdialytic period. So he's fairly compliant with his dialysis, and he has been on dialysis for the past 3 years. His past medical history includes congestive heart failure, hypertension, and diabetes. So again, the morbidity is fairly common in most of our dialysis patients that we see. He has history of coronary artery disease. He's undergone 2 instances of percutaneous angioplasties. He does not have any known valvular or dysrhythmic heart disease, and has had previous admissions at least twice in the past year for decompensated congestive heart failure. And his relevant cardiac tests in the past 12 months, his echo showed biventricular enlargement, and his ejection fraction was 30%. So not in any way an unusual presentation. So when a patient presents with these symptoms and this history, the clinical questions that we need to ask ourselves are what are the cardiac effects of an arteriovenous fistula or an arteriovenous graft for that matter? Does this patient have high output cardiac failure secondary to his access? And should we treat his cardiac failure, or how do we treat his cardiac failure and still preserve his access? Our patients clearly need that access because that's their lifeline, and without an access, how do we dialyze these patients? So yes, we have to think of a situation where the patients don't keep presenting with decompensated cardiac failure, but at the same time are able to also undergo dialysis until, if it's an option, they can get a transplantation, which would definitely be a permanent solution until the transplant kicks in. So with these questions in mind, let me go into the basic access physiology and basic concepts. So an dialysis access, whether it's an AV fistula or an AV graft, it is a circuit. And as you can see here, the circuit starts at the heart. The blood gets pumped into the arterial system. It crosses across the anastomosis. That is what is created. And then the blood return is through the venous system, central veins, and back to the heart. So it's important to know that an AV access is not just an anastomosis. It's not just a surgically created anastomosis. Yes, it is abnormal. It's not a normal situation. You have to create an anastomosis, which is critically important for the AV fistula to mature, but at the same time, one needs to have a good pump, a good arterial system, and a good outflow without any central stenosis. And unless all of these components are taken care of or evaluated before an AV access is placed, the success for an AV access maturation, AV fistula maturation, as well as AV graft functioning would be controversial. So once an AV access is created, how much blood is required for an AV access to support dialysis? And this is important because if you create too large an access, then it creates a tremendous cardiac load. If you create too small an access, then the fistula is not going to stay patent, and you will have episodes of thrombosis. So you need to have an optimal situation, and from various studies we have come to a conclusion that for an AV access, roughly about 600 ml of blood flow is necessary. An AV fistula requires somewhere between 5 to 600 ml, and these are all epidemiologic studies that were done in large cohorts, where maintaining an AV fistula flow of minimum of 500 ml per minute maintains the access patency, whereas in grafts, when the graft flow falls below 600 ml, the risks of thrombosis increases tremendously. And that brings in another concept which needs to be clarified: pump speed versus access blood flow. And often these two terminologies are interchanged, and that's not the right thing to do. Pump speed is what you set on the dialysis machine, and that is completely different from the access blood flow. Pump speed in US, we generally try to maintain a pump speed of between 350 to 400 ml per minute, and I know in India, on an average, it's maintained at between 250 to 300. So pump speed is something that you set on the machine, but to achieve that pump speed, the blood flowing through the access needs to have a certain flow, and that flow is the access blood flow. So an optimal access blood flow is something that will support your pump speed and at the same time maintain the patency of the access. So for an access, again, for an access blood flow, which is commonly described as QA, is the measured blood flow in an access using a Doppler ultrasound. And the minimum blood flow for an AV fistula, as I mentioned, roughly is around 5 to 600 ml, and for AV grafts, it's more than 600 ml per minute. And these are the numbers that KDOQI guidelines has recommended, where if you are familiar with the rule of sixes, where for an AV fistula needs to be at least 6 weeks for maturation. It needs to be minimum 6 millimeters of luminal diameter. It needs a blood flow of 600 ml, and it needs to be less than 6 millimeters below the skin for easy cannulation, and a 6 centimeter length of straight fistula for cannulation, so that your needles are at least an inch and a half apart to reduce the recirculation rate. So again, the rule of sixes includes this concept of access blood flow of less than 600 ml per minute. So does it matter if the axis is distal or if the axis is proximal? And when I say distal, is it a snuff box or a radiocephalic fistula versus an axis at the elbow, which could be a brachiocephalic fistula or a transposed basilic vein fistula? And it does matter. Your arterial luminal size is larger as you go proximal. So your radial artery is smaller than the brachial artery, and naturally the blood flowing through the anastomosis from a radial artery has a less flow compared to blood flowing through a brachial artery into the cephalic vein in the upper arm. So an average axis blood flow in the upper arm, brachiocephalic fistula, is roughly about 1200 ml per minute. And so the distal axes have a relatively lower flows compared to the proximal AV axis, and average axis blood flow in a radiocephalic fistula is somewhere around 600 to 900 ml per minute. And if you're dialyzing a patient, say with a pump speed of 300 ml per minute, you have enough blood that can be pulled for dialysis in the extracorporeal circuit, and enough blood flowing distally to the hand so that your hand is perfused and you don't see, patients don't get symptoms of hand ischemia. So these are relevant concepts that are important when we talk of creating an AV fistula, because the common complications that you can see if the flows are much higher is, one, your cardiac workload goes up, and two, you may have situations where you can either have a Steele syndrome distally, or you can have even venous hypertension. A third concept that one needs to understand when an AV fistula is created, a fistula needs to mature, whereas an AV graft does not need to mature. AV graft needs to heal. So AV graft is a fixed tube. It's a synthetic tube, generally made of polytetraethylene material, and it's a 6 millimeter tube. So there's no question of maturation, it's a question of healing. Whereas for AV fistula, you have a smaller vein through which high pressure blood now flows through because of the anastomosis, and the vein has to dilate and thicken so that you can cannulate during dialysis. So that process, which is called as the maturation, generally starts within the first 2 weeks. So as soon as the access is created, your blood flow through the venous outflow or the vein increases rapidly within a 2-week time frame. And here's a study that showed how these changes happen, and again it helps you to define whether an axis is maturing well, or if it's not maturing well, then you need to take some action and think of alternate plans. So here's an example of a normal fistula. So the upper panel, A and B graph, is normal fistula. This is blood flow. This is the luminal diameter. And as you can see, within 2 weeks, your blood flow increases to about 600 ml, and your diameter increases to about 0.4 centimeters. So again, within 2 weeks, your fistula needs to show real good signs of maturation, which can be easily identified with a good physical examination. And over a period of time, as you can see, by 6 weeks or 8 weeks, it stabilizes depending on where the axis has been created. And 800 ml of blood flow and about 0.5 to 0.6 centimeter of luminal size is good enough to support dialysis. And again, in the Indian setting where the patients are dialyzed with a lower blood flow, you have seen this, and you all are familiar with the axis being used within 4 weeks time frame. On the other hand, panel C and panel D is of axis change in axes that primarily fail to mature. So within 2 weeks, you can see that in this study, the axis flow was about 200, and over a period of time, instead of increment, there was a drop in axis flow. Similarly, there was a fall in the axis diameter or the outflow diameter. So if the axis fails to mature within 4 weeks time frame, you see that the axis is weak, there is very poor thrill, there is poor augmentation, then that's clearly an indication that something needs to be done. You can do a Doppler ultrasound to evaluate this more objectively, and then if there is an option to intervene, one should perform an endovascular intervention or send in for a proximalization or another anastomosis so that the axis eventually matures. So with this background about the physiology, how does an AV axis impact cardiac function? So the cardiac function increases, the cardiac output increases by about 15% when you create an AV axis. So these are the early effects. There is increase in the left ventricular end diastolic diameter, which increases the left ventricular diastolic dysfunction and restrictive filling pattern. And simultaneously, there is an increase in both atrial natriuretic peptide as well as brain natriuretic peptide. And because of the increased cardiac output that needs to be now compensated, there is decrease in peripheral vascular resistance. And all of these effects are generally seen within a 2 weeks time frame. So within 2 weeks of creating an AV axis, not only do you see local changes, as we discussed, of increase in flow through the vein and increase in luminal diameter, but you also see cardiovascular changes. So there is increase in blood volume, there is drop in systemic vascular resistance, and there is increase in cardiac output. And with the increase in blood volume, naturally you will have increase in right atrial pressure and pulmonary arterial pressures, and increase in both atrial and brain natriuretic peptides. By 3 months, because of these changes, there is increase in left ventricular mass and left atrial dimensions. And by 3 to 6 months time, because of the increase in left ventricular mass, there is subendocardial relative hypoxia, which again leads to left ventricular dilatation, and then over a period of time it can lead to left ventricular ejection fraction. Not everybody will get decrease in left ventricular ejection fraction, but you can see that especially in patients who have underlying pre-existing coronary artery disease. So what we really know that patients with chronic kidney disease are more prone to developing coronary artery disease, and patients with coronary artery disease are more prone to developing chronic kidney disease. By creating an AV fistula, we are actually making these conditions even worse. So how about the long-term chronic effects? So the long-term chronic effects are mainly three. The left ventricular hypertrophy, which is again an adaptive response that we see to the increased cardiac workload. That's an ongoing effect from what we see in the initial 2 weeks to 3 months time frame. High output cardiac failure, which is related to the vascular access blood flow, and that's why it was important to understand where the access is, how big the anastomosis is, and what is the access blood flow. Again, proximal accesses have a higher blood flow compared to distal accesses. So brachial arterial inflow access, which could be either a brachiocephalic fistula or a transposed basilic vein fistula, can have a higher access blood flow, leading to left ventricular hypertrophy, enlargement, and then dilatation. And patients who have pre-existing ischemic heart disease or coronary arterial disease, because of myocardial oxygen, increased oxygen consumption, they are at a risk of developing worsening of their coronary artery disease. There's the increased oxygen demand with fixed supply because of the dilated and enlarged heart makes it in the coronary arteries to dilate further, and these patients are again more likely to have coronary events. So to summarize on the long-term effects of cardiac effects of AV fistula, initially there is increased blood volume and increase in cardiac output that leads to right atrial pressure increase and increase in pulmonary pressures, eventually leads to left ventricular end diastolic pressure increase, myocardial damage and LV dilatation, and reduction in ejection fraction and congestive heart failure. Now, how about the right-sided changes? So pulmonary hypertension and vascular access are again the effect of vascular access on pulmonary hypertension is very well known. So if you recollect, systolic pulmonary arterial pressure is equal to cardiac output times pulmonary vascular resistance, and systolic pulmonary arterial pressure of more than 30 is considered as hypertension. If it is more than 45, if it is 45, 30 to 45, it's considered as mild pulmonary hypertension. Between 45 and 65, it is moderate, and more than 65, it is severe. And again, 40% of our patients who are on dialysis do have pulmonary hypertension. The more fluid overload these patients have, more likely they are going to have pulmonary hypertension. So again, this is something that compliance on dialysis is important, but even with compliance, patients do have a higher cardiac output compared to patients who do not have an AV access. These patients do have a higher cardiac output, and unless we look for this problem, we are going to miss this, and that's often what is seen in clinical practice. Chronic vasoconstriction in the pulmonary vascular bed, again, if the patient has pulmonary edema or patient has higher systemic pressure, these patients do have chronic vasoconstriction, which can again add to the problem. So high cardiac output from AVF contributes to pulmonary hypertension. And how do we know this? because patients who undergo transplantation or patients where the access is ligated for whatever reason, and in those patients, if we measure their pulmonary pressures, there is reversal of the trend of pulmonary pressure. So clearly, AV access contributes to pulmonary hypertension. So where does high output cardiac failure fit into this whole scenario? So high output cardiac failure, it's a clinical syndrome. Patients generally are symptomatic. So they have dyspnea, orthopnea, and fatigue. And as we discussed, these are fairly common symptoms that we see in our patients who are on chronic hemodialysis. Patients are anemic, patients are volume overload, they have decompensation of their functional capacity. So these patients do complain of easy fatigue and shortness of breath. But a high index of suspicion is essential to diagnose high output cardiac failure, especially if the patient is fairly compliant on dialysis. If the patient achieves their dry weight at the end of each treatment, then one really has to keep in mind and look specifically for evidence of high output cardiac failure. If the anemia is hemoglobin is more than between 9 and 11 grams per deciliter, less likely that it's just the anemia contributing to high output cardiac failure. And in these patients, when we do specific tests, their resting cardiac output is generally more than 8 liters per minute, or if you measure the cardiac index, it's generally more than 3.9 liters per minute per meter square. And the AV access flow is generally more than 2 to 2.5 liters per minute. So again, as a reminder, the rule of sixes, NKF, DOKI guidelines, you only need 600 ml to provide adequate pump speed and maintain access patency. So if an access flow is more than 2 to 2.5 liters per minute, the risk of developing high output cardiac failure is much higher. So the other risk factors include the underlying cardiopulmonary status. So if a patient already has coronary artery disease or ischemic cardiomyopathy, before he gets an AV access created, he or she gets an AV access created, and if they already have a New York Heart Association classification of CHF, NYHA class 4 CHF, they have unstable coronary artery disease or severe pulmonary hypertension from lung disorders like chronic obstructive pulmonary disease, if they have been a heavy smoker, and if they have COPD, and if they have pulmonary hypertension, or if they are morbidly obese, like we see here in the US, a large number of our patients are morbidly obese, they have sleep apnea, and they are smoker. So underlying pulmonary hypertension is fairly common. So if patients do have these underlying symptoms and diseases, again, severe valvular heart disease, which I would think mitral valve regurgitation, which probably would be more common in India from rheumatic heart disease. I don't know if that epidemiology has changed, but clearly these are underlying conditions that one has to think of would be risk factors once an AVF is created for these patients to decompensate. Upper arm fistulas versus forearm fistulas. Again, we discussed the blood flow in the upper arm fistula is much higher compared to forearm or distal fistulas, and again, it doesn't matter whether it is AV fistula or an AV graft. In fact, with AV graft with a 6 millimeter fixed luminal diameter, the blood flows are generally much higher. Male gender somehow is predisposed to more decompensation, and multiple access surgeries. I mean, if they've had access for a few years and then that access has failed and now they've moved to another access, that means longer time frame, longer high cardiac output status can eventually lead to cardiac decompensation. So here's a study that clearly highlighted the risk analysis of high output cardiac failure in the dialysis population, and this is actually one of the seminal studies that that has helped us define high output cardiac failure in the dialysis population. And in this study, they had about 96 patients, and patients who developed high output cardiac failure, their access blood flow was more than 2 liters per minute. And they clearly showed the higher blood flows in the upper arm. Upper arm axis had a blood flow of 1.6 liters per minute, whereas forearm axis had a roughly 1 liter per minute. And a large number of these patients had underlying congestive heart failure and intrinsic heart disease to begin with. The diagnostic tests that one needs to use for AV access for related congestive heart failure is, again, you have to measure the access blood flow to cardiac output ratio. If it is more than 30%, then the risk is higher. And a very simple bedside test, the Branham sign, which is essentially you compress the AV access, and compress the AV access and there are various techniques that have been reported, 10 seconds, 30 seconds, or 60 seconds. So you compress the AV access and you measure the pulse rate. I mean, it's a simple bedside tool. If there is bradycardia, and that bradycardia is defined as 10 to 12% drop from the baseline heart rate. If there is bradycardia within 10 to 30 seconds, then it's very indicative of the AV access contributing to a large amount of cardiac output. And if a patient has the symptoms or the prodrome that we discussed, then very likely the AV access is contributing to congestive heart failure. If you can measure the cardiac output, you can see the cardiac output drop even within 10 seconds. So clearly a simple bedside tool that can be used to identify high-risk patients. One of the concerns that most people have is how can we occlude the AV access for 10, 30 seconds or 60 seconds? Will the access clot? And generally, that has not been reported, that is not seen in clinical practice. 10 seconds of occlusion clearly will not occlude your AV access. So the concerns for performing this bedside sign leading to increased thrombosis is unfounded. So once you have diagnosed that the patient has an AV access related congestive heart failure or high output cardiac failure, we are in a dilemma. If a patient was not on dialysis, it would be easier to go and treat them with diuretics, beta blockers, and whatever other else intervention is needed. In our patients, things get complicated because we not only have to manage the high cardiac output, but at the same time, we also have to maintain the AV access, which is essentially the reason why these patients go into cardiac failure. So how do we find a common ground where the patient is not symptomatic, but at the same time we maintain the access patency so that they can be dialyzed on a regular basis? Again, just to reiterate, the clinical signs of worsening cardiac disease: increasing shortness of breath, wide pulse pressures, and very high heart rate, so they have tachycardia. When you occlude the AV access for 10 to 30 seconds, you will see a drop in their heart rate from baseline. A chest X-ray will show cardiomegaly, and monitoring access blood flow to cardiac output ratio, if it's more than 30%, it's associated with increased risk of heart failure. So that's in a nutshell how you would clinically suspect an AVF-related decompensation of cardiac function. So what I'm going to focus on now is how do we handle these AV accesses that are the reason why patients go into high output cardiac failure. So when we know about when the access matures, you have the venous side that dilates and the venous luminal wall gets thickened. But what is often not appreciated is that the proximal artery, the feeding artery, also hypertrophies. And here's Here's an example where the brachiocephalic fistula, the brachial artery, proximal brachial artery, is really very large and thickened. Normal brachial arterial blood flow is about 60 to 80 ml per minute. When the fistula is created, that increases from 60 to 80 ml to about 1.5 liters per minute. So the artery also has to accommodate such high volume of blood, and that's the reason why sometimes it is really difficult. It's in post-transplant patients where if one tries to ligate the AV axis, because of the high blood flow in the arterial tree itself, ligating just the fistula may not necessarily turn out to be an optimal solution, and one has to really evaluate how that high flow through the arterial tree is going to eventually get diverted if you ligate the fistula in a post-transplant patient. But the point I'm trying to make here is the hypertrophy and dilatation happens on the venous side as well as on the arterial side. So to target the access therapy to reduce or minimize the risk of high output cardiac failure, there are two strategies that can be employed: inflow reduction technique versus a modality change. Inflow reduction can be banding or distal reanastomosis, and as a last resort, just ligate the AV axis, so there is reduction straight in the cardiac output. And alternatively, in patients who really are at a very high risk, one should consider alternate therapy like peritoneal dialysis, which eliminates the need for creating an AV axis. Briefly, in my next few slides, I will go over some of the surgical techniques that are used. So you kind of plicate so this is an AV graft. So you plicate the AV graft either at the arterial anastomosis or in somewhere along the loop, and basically you are reducing the blood flow. Again, the risk of this procedure is the blood flow reduction can lead to thrombosis, as this is an arbitrary way of ligating or minimizing the blood flow. On the AV fistula side, the anastomosis luminal size can be reduced, and some other surgical techniques are using Rudy technique or drill technique, which you may have heard, distal revision with interval ligation. Here, so this is a fistula, and what you essentially do is place a graft more proximal to your arterial anastomosis and then connect it distally beyond your anastomosis, so that the blood can be diverted in both through the axis as well as to the distal circulation, and then the interval segment is ligated. The problem here is your distal circulation now is totally dependent on a graft that you have created. So if this graft thromboses, then you are in bigger trouble, because now you have to worry about distal ischemia. As opposed to that, revision using distal inflow, so here's an axis that is created. So you ligate, so you create another anastomosis distally. So now your blood flows from the artery beyond the original axis through the new anastomosis into the dilated vein, and then you ligate the dilated vein, the original anastomosis. So again, if you're this newly created graft thrombosis, you're still not compromising the distal circulation. And another technique that has been used is create an entirely new anastomosis by proximalizing it. So your anastomosis, which was here, is ligated, and you place a graft and go as proximal as possible to a larger artery. So in this case, it's the axillary artery to cephalic vein, and that graft, it could be a venous graft, it could be a prosthetic or a synthetic graft, and that feeds into the fistula, and that's called as proximalization of anastomosis. So these are some of the approaches that have been used to reduce the axis blood flow, and when you create these new axes, you can control the amount of blood volume of blood that's flowing through the fistula. As an interventional technique, we can perform this by placing a balloon. So you puncture the venous side, place a small sized balloon, generally a 4 millimeter balloon, across the anastomosis. So the balloon is placed, and then you tie a ligature around the balloon, so that way you have a controlled reduction of the luminal size, and that helps in reducing the access blood flow and eventually reduction in the symptoms. Does this flow reduction really help? So these techniques have been done and they have been reported. They're clearly the inflow change was significant. So initially the inflow, which was anywhere from 2,000 to 4,000 with a median of somewhere between 3,000 blood ml per minute, dropped down to close to 1 to 1.2 liters per minute. And the cardiac output, when the access inflow was reduced, dropped from 8 liters on a median to about 5 liters per minute. So clearly, access flow reduction can help, and continue using the same access for supporting dialysis. Again, another study that showed that access flow reduction from 3 liters to 1.2 liters helped both with the symptoms as well as maintaining the access. How about the interventional technique? The interventional technique that I showed, the first report was presented in 2010. They had about 69 AV accesses, and the 6-month patency was 85%, 2-year patency was 90%. Thrombotic episodes were no different than what you would normally see in an otherwise a patient with an AV access without any cardiac decompensation. Subsequently, another study with a small number of patients also showed that 6-month and 1-year patency was about 83%. So clearly, all of these techniques work. The idea is we have to identify these patients, and then whatever your resources are available, you have to utilize them to the best possible way. So in my practice, what I generally do is if I have a high-risk ESRD patient, I try to see if they agree to go on to peritoneal dialysis. If they agree to go on peritoneal dialysis, then upfront, the problem of cardiac output, high output cardiac failure can be prevented. So something that you can talk to the patient and try and educate, and if they agree and if they have resources to perform PD, that would be an ideal solution. If the patient does not have an option to consider peritoneal dialysis, then the key thing that I look at is life expectancy. If the life expectancy is more than 1 year, and if preferably would consider a distal AVF creation. If radial is not possible, even creating a proximal forearm fistula is much better than moving on to a brachiocephalic fistula. And if that's not an option, creating a brachial cephalic fistula, so alerting the surgeon well enough that the patient is likely to go into congestive heart failure post AVF creation, the AVF anastomosis should be as small as possible, generally 0.4 millimeters of anastomosis. So the surgeon has to be competent enough to create an anastomosis which is less than 0.5 millimeters, and these patients are then closely monitored with the ratio of access flow to cardiac output, clinical signs, and at the earliest indication, some kind of intervention. If the life expectancy is less than 1 year, then I generally keep them on tunneled central venous catheter. Again, tunneled central venous catheters, not non-tunneled. So to summarize, cardiovascular disease is common in dialysis patients. Assessment is essential for access planning. Clearly something that needs to be evaluated in the elderly patients and diabetic patients and patients with pre-existing coronary artery disease. Cardiovascular status can dictate the modality of renal replacement therapy, and if there is a potential for renal transplantation, that should be pursued more aggressively. It is a complex decision process with pre-existing heart failure, but again, not a complete or an absolute contraindication for not creating an AV access. Patients with severe congestive heart failure clearly are at high risk, and it should be so explained and discussed with the patient, and preferably the long-term goal should be discussed with the patient and not just the goal of maintaining dialysis. And again, peritoneal dialysis may be preferred in these high-risk patients. So with this, I end this talk, and I think to test your attention of this talk, I think we have 3 poll questions, which I think Vivek is going to launch.